All right. Well, thank you for coming down from the big city, New York.
Okay.
You said you got in last night?
Yes, and we were, after this, then we're heading home.
Gotcha. All right. So, these issues with your heels have been going on how long again?
About 18 months.
18 months.
Give or take.
Which foot did it start first?
This one.
The left one?
Yeah.
Okay.
And this one started this year.
And it started here, you said, first?
No, it started at the heel.
The heel.
Yeah, it was inside, right where your finger is right there. Yeah. And then it was weeping at first when I contacted you. And it kind of dried itself up. Then I went to see the foot doctor. And it was come back, every 2 weeks.
All right.
Though the cream on, it just progressively got worse other than better, so.
All right. So how is the itching doing now? You told me it was itching a lot earlier.
It itches when it's dry, out of the blue.
Okay.
And I rub it.
So have you ever been prescribed a steroid cream?
Other than urea, no.
No. Okay.
I had a pill. I can't remember the name of the pill, but she told me, the side effects in terms of the liver and all that stuff.
Right.
So it was an internal.
Was that for a fungal medication?
Yes.
Did you have an issue with your nails? Because your nails look fine.
No, I find it good, yeah.
Okay.
But she did not know what that was, nor did she take any samples or anything, so.
Got you. All right, so this area on the inside of your left heel, where it's dark,
yeah.
I think the word you were looking for earlier was lichenification.
Oh.
Does that sound familiar?
No.
The word that you were given?
No.
All right, so when the skin here starts to really thicken and crack and become like these individual like little islands.
Correct.
Okay? That's lichenification.
Those little islands are the ones that itch.
All right. Now, do you ever have any drainage from them in that area?
No.
Okay.
If I over itch them, then they'll get a little, watery, for lack of a better word, yeah.
Okay.
Then.
All right, so start working on this a little bit. You let me know if it's uncomfortable, okay?
Okay. Because I can't see you do it, it's a beautiful thing.
Okay.
If I was looking, I'd be flinching right about now. So, if you see my toes curl, then it's just nerves.
And how long did you say you've been watching the channel now?
Over a year.
Over a year. Okay.
Yeah. Round about the time again, like I said, with the lady with the heel fissure. Because I thought I would have to have had done that. That was way before this how it spread the way you see it now. And I thought I was the only one in the world. That's why, there's a fear and a humbling. Because that's why I don't do pedicures.
Right.
If that makes any sense to you?
It makes sense. The thing is, though, is that these issues are actually more common than folks think. Right.
See, I haven't worn a decent pair of, like, as you would say, slingback or anything like that. Or any exposed heel.
Right.
Let's put it that way. And I always buy pumps that are covered. Just because I do not want anyone to see any cracking in my heels. Some people's vision is micro.
Right.
They zero in.
So you have some pretty deep fissures in here too. Now, do any of those ever cause you any pain?
No pain. When they dry, they crack. I just feel the pinching.
Got you. Now, you said you were working on them a little bit and it would bleed?
No, that's the doctor.
Oh, the doctor you saw in New York. Yeah. Now, what I'm doing here now, the debridement, how often has that been done?
None.
None?
None at all.
Really?
Nothing. Because she was afraid because she didn't want to nick me in. Because she says if, when it causes them to bleed, they can get infected.
Yeah. Especially that in combination with the diabetes and everything, you got to be very careful, very judicious. It's coming down pretty easily here. There we go. Now, whenever we deal with these significant and harder to deal with skin issues, I always caution patients that we have to deal with it on several fronts. It's not just a medication, it's just not a cream. We have to deal with those issues. We have to deal with trying to figure out what caused it in the first place. Okay. Since you do have a history of eczema, in other parts of the body, I'm definitely going to recommend that you, when you get back home, that you see a dermatologist there in the city, New York City, to see what's going on with just the body-wide issue. Because I notice here, like on your calves, your legs are extremely dry. I know it's cold today too. Yeah. So do you have issues during the colder months?
I've not really paid too much attention to that. Because usually, like I said, right now they stay dry because I haven't lotioned anything.
It's coming down pretty good here now. So we also have to look into biomechanical causes. Okay. Or at least biomechanical factors that either cause it in the first place or exacerbate it, make it worse. Okay. So when we see that people have very flat feet or very high arch feet, in the heels in particular, that can lead to increased pressure, increased friction between the shoes and the skin. And that can make the issue harder to treat. Because as you're applying the creams and medications diligently every day, because of possible biomechanical issues, you're actually fighting against what you're trying to do.
Well, the strange thing is that this recently, when I say recently, in the past year or two, my ankles used to be about as big as my calf.
Really? Why was that?
Huh?
Why was that?
So edema. That was just the I would just say the diagnosis, the edema, the swelling. No one, pretty much, just elevate my legs to get the sun to go down on my days off. Just elevate my legs and they would go back to a little bit bigger than what they are right now. But they would never stay. Within an hour of walking or so, you could see the pooling. Right. And then the shape of my foot would be in my shoe when I take off. But then the whole foot and the ankles would be waterlogged.
Now, have you ever had that situation evaluated, the vascular system of your legs and feet?
No.
No, okay. So you haven't been to a vein specialist or vascular specialist at all?
No.
Okay. So that needs to be put into the program as well. Okay. Because these issues are often multifactorial. I've never seen just one thing cause this. There we go. And so, because the issues are multifactorial,
Mm-hmm.
the treatment has to be multifactorial.
Okay.
There's no magic bullet. There's no magic cream in a tube.
Mm-hmm.
It's going to make all this go away. All right, so we can see the fissures develop just because of the daily pressure of walking.
Mm-hmm.
You know, as pressure is put on the skin, on the heel, the skin starts to separate, forming these fissures here. And then over time, as the process replicates day in, day out, the dryness, the inflammation, the buildup of the skin, the dryness, the inflammation, the buildup of the skin, you get this lichenification.
Okay.
Along with the fissures. All right. Now, the doctor you saw in New York was correct that we have to be very careful when we debride around the lichenification, because the blood vessels in these areas are very superficial.
Okay.
So I'm not as aggressive in this area as I was on the back of the heel and the bottom of the heel here. You said you haven't used any steroid creams, right?
No.
Okay. Well, that definitely needs to be part of your program here. Now, another thing you have to be cognizant of this area of lichenification, and make sure you don't get a lot of moisture in this area, because these cracks, these crevices, they will hold moisture like a sponge.
Okay.
And that's when people start having issues with bacterial infections, bad odors.
Well, you know, the
Things like
funniest thing, years ago,
Mm-hmm.
I'm talking like more than 5 years ago, when my feet used to sweat a lot.
Mm-hmm.
Then I guess I can say, thinking about it, it stopped sweating. They used to sweat so much they smelled like a dead rat. Funky. But I have not had that in quite a while.
Right. Now,
Yes.
one of the things that we notice, particularly in the feet of our diabetics, is the loss of sweating or decrease in sweating.
Okay.
That's a sign of neuropathy. And why it's a sign of neuropathy is that sweating is controlled by the nervous system.
Okay.
All right, so when there's neuropathy or early signs of neuropathy, that's sometimes one of the hallmark things we see is extremely dry skin.
Now, what is neuropathy again?
Neuropathy, to put it simply, is nerve injury or nerve damage.
Okay.
Whether it be the small nerves going to the skin, or, you know, very large nerves, like when people have sciatica. Sciatica is a neuropathy. Carpal tunnel syndrome is a neuropathy. Yeah. When you fall asleep in one position, you get numbness in your fingers. It's temporary, but it's a neuropathy.
Okay.
So this area of lichenification is going to need some pretty intense topical steroid
Okay.
that will do to help reduce the inflammation that's part of the process. This is looking much better. Then you don't want to be too aggressive here.
See, right, yeah, right where
Yeah.
where your thumb is,
Yeah.
that's kind of around the area that itches a little.
Okay. Work on this side now. Now, what you'll have to do at home is work on these skin areas daily.
Okay.
Now, especially because you have diabetes, you don't want to use anything sharp.
Right.
You don't want to use one of those scrapers or pet egg or anything with blades, little micro blades.
I did use at some point one of those grater things if you strongly disagree with using.
Mm-hmm.
And I don't use it. It kind of got to the dead skin per se.
Mm-hmm.
But it wasn't something I did on a regular.
Gotcha.
Because it's the point I could just use my fingernails and kind of scrape away the dead skin, but it was still not hitting the meat and potatoes of it.
So, since we give you a big head start here, at home, you'll be able to use like a callus file or a pumice stone or something with sandpaper, no sharp edges.
No.
So after you bathe, to work on these areas daily. Where most people go wrong is that they'll work on it once a week, maybe a couple of weeks. Then it builds up and then they do it again.
Oh.
You know, they wait till it gets to a point, then they work on it again at home. When actually the best way to deal with these things until it really gets under control is do a little bit every day. Don't try to do it all at once.
Okay.
Because that's how you end up irritating the skin and possibly suffering an injury. Just work on one little area, maybe a square inch a day. Okay. And you want to be able to keep that thickness of the skin down so that the medications you are using will be more effective.
And penetrate better.
Exactly. So I don't care what you try, with the skin being as thick as it was when you came in, that wasn't going to work.
Okay.
Not with as thick as your skin is. Now that you
So that lotion I can put on as soon as I get home.
You get that ammonium lactate you brought in?
Yeah.
Yeah, that would be fine. Now, ammonium lactate is more of a moisturizer than it is a skin softener.
Oh.
Okay, which is good. I mean, it does soften the skin to a degree, but by itself, it wasn't going to take care of this.
Okay.
We prescribe ammonium lactate, particularly in our diabetic patients, very often because of its moisturizing capability, and you will need that. But you were on the right track when you were using urea before. You remember what percentage you were using?
That's all I think is 12.
12? Okay. Well, the ammonium lactate you have is 12.
I'm sorry?
The ammonium lactate, the big body
that
product,
one is 12.
that's
Yeah.
12. Urea, I'm going to recommend you do 40%.
Oh, okay. So, okay.
And urea, you can get 20, you can get 40, you can get 47.
I'm thinking that was urea.
No, that's ammonium lactate.
Okay.
That's a different medication altogether.
That is this fungal or?
No, it's not. See, this is not a fungal infection. This is not athlete's foot.
Oh.
That's another thing where people get mistaken. I think it's a fungal infection. And they'll go out and get some antifungal cream, spray, powder, or whatever. Of course, because it's not a fungal infection, they're not getting any results, and it continues the frustration. All right, you got a couple of fissures here on the outside of your right heel.
Okay.
So again, that's dealing with biomechanical issues. Now, on a regular basis, do you wear socks or stockings?
Yes.
Good. Definitely continue that, because the socks and stockings will help decrease the friction
Normally, I lotion my feet. That put this just kind of keep in the moisture, as to prevent it from drying out.
Gotcha. What about any night treatments? Do you do any night treatments?
Other than, like I mentioned, the wrapping my heel with the self-stick bandage. To kind of, keep in the moisture. That's pretty much it.
Yeah. Okay.
But that's not on the regular either. Sporadically, I do that.
So here's what I recommend you do.
Okay.
All right. Since how many hours a week are you working?
40.
All right. And you go into the system to work, right?
Yes.
Okay. So.
And I do a lot of walking around.
I walk around. So, what I would recommend is that you use the ammonium lactate in the morning as you're getting dressed for work. In the evening, you should use the urea.
Okay.
40% or 47. And then after you put the urea on, put on a pair of socks. All right, just don't put them on and just get in the bed. Okay. That's going to do more skin softening.
Okay.
And the steroid I'm going to prescribe for you today, steroid cream, is what you're going to put in this area of lichenification. All right, so there's 3 things you're going to need to apply on a daily basis.
So the urea in the morning, on the way to work.
No, the ammonium lactate. I'm going to write it all down for you.
Okay.
The ammonium lactate in the morning. The urea at night with a pair of socks. And then twice a day in this area, lichenification with the steroid cream. Okay. And always keep in mind that the most important thing that you need in dealing with this is patience.
Okay.
This is not an overnight treatment. It's not, there's no magic here. All right. It's dealing with things on multiple fronts. Then there's the biomechanical issue that we need to talk about. And trying to control the forces of your heel as you move around. So when we finish this here today, I'm going to do a scan of your feet so we can see where your high pressure areas are.
Okay.
To see if that's contributing to the issue that's happening here.
Would I need one of those special orthotic shoes?
You may not need the shoes so much,
Okay.
but an insole you would definitely need.
Oh, okay, okay.
What type of shoes do you wear most often to work?
I have a pair of Skechers and a pair of Fila. Mostly for walking.
Gotcha. Now, do you do any walking for exercise or fitness or anything like that? Any other type of activities?
No.
Okay.
No.
All right. We have a good take here today. It's a lot. Turn over, check us out. Take a look at what we got.
Oh, damn.
Yeah. That's all from you, my friend.
Oh, good.
That's quite a bit, right?
Yeah.
Okay.
Yeah.
Rotating pretty quickly. Yeah. The water on first. Now, whenever you're doing these treatments at home, again, always after you've been in the tub, never do this dry, and use a circular motion.
Oh, okay.
Not linear, not up and down, back and forth, but in circular motion, in small areas. And another thing I'm doing counter traction.
Okay.
So what I'm doing is I'm pulling on your heel at the same time.
Okay. That's to get into a little.
Make the skin a little tighter as I'm working on it. You've watched the channel enough to know how much I like shea butter, right?
Yeah.
That's something else you can apply as part of your program. All right. So I like it because it's more of an emollient. So it has properties of water-based properties like creams and oil-based properties like Vaseline.
Okay.
We also have coconut oil, tea tree oil, lavender oil, jojoba oil, and a little peppermint oil that helps to with some of the inflammation that you have. All right. So yeah, every day you're going to want to deal with these issues. Don't wait for it to build back up.
Okay.
If you keep waiting for it to build back up, you'll never get ahead. You know, I tell folks, you know, even after a good debridement like today, that's just the beginning, it's not the end.
Right.
A bit more here. But now, today, we're moving in the right direction. There we go.
That feels really smooth.
It's not as angry looking as when you first came in.
You're very angry.
Yeah, that's what we call it. That's actually a medical term.
Oh.
All right. How we feel here?
Good.
Excellent. All right, so we're going to go do the scan in a minute. But I like what we're seeing here. I'll take some pictures. Can you see? This is Dr. Kevin Jefferson, the DC Foot Doctor. Thank you for watching this video. Like it with a big thumbs up to see very interesting cases and my approach and techniques to dealing with them and how to learn how you can improve your foot health. Subscribe to the channel. Ring the bell so you will know when a new video has been uploaded. Follow me on social media at DC Foot Doctor. Most importantly, take care of your feet.